Hi, my name is Dr. Chris Doughty, and I'm a neuromuscular neurologist at the Brigham and Women's Hospital in Boston. In this session, we're going to cover neuromuscular disorders in pregnancy. We'll go through a series of 4 cases to go through the topics you see on the outline here. Let's jump right in. So for case 1, we have a 32-year-old female who's presenting with bilateral hand pain and paresthesias at 31 weeks pregnant. This is her first pregnancy. She notes that she wakes up from sleep with this pain and that her hands feel like they're asleep with tingling in them. She has pain that radiates into her forearms when it's particularly severe, and she denies any neck pain. On examination, she has a positive Tinel sign bilaterally. She gets paresthesias in her fingers with the Phelan maneuver, which is pictured here, and she has numbness to pinprick testing on the right thumb and the palmar aspect of her second finger. This case is fairly consistent with carpal tunnel syndrome. She has typical symptoms, and the examination findings are suggestive as well. This is one of the most common neuromuscular complications that we can see in pregnancy, with rates estimated between 17 and 60% based on the cohort that we look at. In addition to the maneuvers that you've already heard about, sensory testing on exam can be helpful for confirming this diagnosis. In particular, really stressing the boundaries of the median nerve territory. So for example, establishing numbness that splits the 4th digit as you see here. Likewise, in more severe cases, we might see weakness of the thenar muscles of the thumb, and testing thumb abduction as pictured here could be useful on examination. In pregnancy, these cases tend to be less severe than idiopathic cases of carpal tunnel syndrome. But about 70% of the time, it's bilateral, affecting both hands. And in terms of what might cause this, there is an association with the amount of self-reported fluid retention that the patient reports. And as a result, it's not surprising that most cases do emerge in the 3rd trimester when this would be most significant. Because symptoms typically improve soon after delivery, if at all possible, we try to use conservative management for carpal tunnel syndrome that arises in pregnancy. So wearing a wrist splint, especially at night, and behavior modification would be first line. For those patients that have more severe symptoms or who do not respond to these more conservative options, a steroid injection into the carpal tunnel is a good intermediate step. For our patient, she was started on wrist splints at night, and her symptoms did improve with this intervention. She had a successful delivery, and about 2 months postpartum, she reported that her symptoms had more or less resolved. It is important to note, though, that for some patients, this can be a more persistent issue. And in some survey studies, about 50% of women go on to have mild persistent symptoms even a year after their delivery. It seems that an earlier onset of symptoms in pregnancy and higher weight gain during pregnancy might be risk factors for these more prolonged symptoms. Let's move on to case 2. This is a 38-year-old with type 2 myotonic dystrophy who is thinking about trying to become pregnant. She was diagnosed with the myotonic dystrophy in her early 30s after she presented with difficulty standing from a chair and difficulty with walking longer distances. She also notes muscle pain throughout her body. She did have 1 early-term miscarriage at the age of 32, and she is married. Her husband is healthy and has had no prior children. So when we're thinking about how to advise her, of course, we should remind ourselves what myotonic dystrophy is and what some of the specifics here might influence our recommendations. Myotonic dystrophy is one of the more common types of muscular dystrophy that we see. And in general, it causes a combination of muscle weakness as well as the phenomenon of myotonia, which is difficulty voluntarily relaxing skeletal muscle. Importantly, there are 2 major types of myotonic dystrophy, type 1 and type 2. Both of these are autosomal dominant repeat disorders. Type 1 is a CTG repeat disorder. Type 2 is a CCTG repeat disorder. The pattern of weakness that we expect in these conditions are actually quite different from one another. The figure you see here is a depiction of the muscles that tend to be affected with type 1 myotonic dystrophy. So in addition to some of the axial neck muscles, we can see facial weakness, diaphragmatic weakness, and distal limb muscle weakness. By contrast, type 2 myotonic dystrophy tends to have a more stereotypical myopathy pattern of proximal muscle weakness. There are some additional differences that are worth pointing out. So type 1 is really a multi-system disorder. Patients can have cognitive impairment, cardiac involvement, cataracts, and very importantly, from a pregnancy standpoint, smooth muscle like that in the uterus can be involved in this disorder. Another really important thing to note is that anticipation occurs in this CTG repeat disorder. So with each successive generation, the disease can get worse. This is especially true when the disease is passed on from a mother to the infant. Type 2 is different. It's more skeletal muscle restricted. We don't tend to see the same amount of systemic involvement that we do with type 1, and we do not see anticipation with this disorder. So because of the phenomenon of anticipation we see with type 1, some infants, actually a full 1/3 of infants born to affected mothers, have a very severe form of this disorder called congenital myotonic dystrophy. And this can be quite severe. It can cause polyhydramnios, clubfoot, hypotonia, and breathing and feeding problems in the infant. This disorder certainly impacts the lifespan as well. Even if we don't see this, there are certainly higher rates of other complications throughout pregnancy in mothers that have type 1 myotonic dystrophy. The situation is a little bit more optimistic with type 2 myotonic dystrophy. There is a risk of preterm labor, and affected women with this disorder do have a higher rate of urinary tract infection during pregnancy. But again, there's not the risk of anticipation in the newborn and overall fewer complications. It is important to note that both of these disorders affect fertility, and about 1/3 of pregnancies in both types do end in miscarriage. So I think this overview of myotonic dystrophy can be helpful in how we would think about our strategies for counseling this patient. But of course, this is a very rare disorder. And I think this is a challenge with a lot of our genetic neuromuscular conditions. For many of them, you might only see a couple cases throughout your entire career, right? And so it can be hard to really think about in advance how you might counsel somebody like this with a super rare condition. But I think there are some patterns we can use to help predict, what the mom might expect, right? So one consideration is how much proximal weakness and how much smooth muscle involvement there is. These things really influence how a patient might do during pregnancy and delivery. The more proximal weakness there is in general, the higher the chance that we might need to use assistance during delivery, for example. Cardiac involvement occurs in some genetic myopathies, and it's very important to know about it before pregnancy because the added weight and fluid retention can really put a strain on the heart. And so if patients have one of these that is known to be associated with cardiac involvement, if they haven't had appropriate screening, this should be done before they think about becoming pregnant. Likewise, respiratory muscle weakness is important to know about because the growing fetus within the abdomen would certainly exacerbate any restriction in lung capacity that these disorders might cause. There is a preterm delivery risk really across genetic muscle disorders. This tends to be the most common and consistent risk during pregnancy for patients such as this. And one final thing to note is that it is actually relatively common for mom to report worsening of her own neuromuscular symptoms throughout the course of pregnancy. And unfortunately, a lot of times this actually doesn't improve after delivery. This is almost nearly universal in a patient with myotonic dystrophy. And you can see here that across a sort of subset of other neuromuscular conditions, the rates get pretty high as well. I think the general way to think about this is that we can see a cycle develop late in pregnancy where, a patient with proximal muscle weakness, the added weight gain of pregnancy really might put a strain on these weak muscles, and they might actually lose the ability to walk independently. As they, deliver and then are trying to lose the weight after pregnancy, it might actually be quite hard to do that if they're requiring gait assist and, they can't exercise as easily as they might otherwise. And so it creates this cycle of deconditioning, inability to take the weight off, and never returning to one's prior baseline. So this is a really important, I think, thing to stress to patients who are considering pregnancy, that it could impact their own symptoms even after successful delivery. So let's move on to case 3. So this is another patient with a neuromuscular disorder, but this time an acquired one. So we have a 34-year-old female with acetylcholine receptor positive myasthenia gravis, who's presenting after her first conception. This is her first pregnancy. As a reminder, myasthenia gravis is an autoimmune disease that is affected against the neuromuscular junction. So she was diagnosed with myasthenia at the age of 23 after she presented with ptosis and diplopia. Her symptoms improved on a combination of prednisone and pyridostigmine, and she was actually able to stop these initially after about 6 months. A few years later, she had recurrent symptoms, and this time she also developed dysphagia. She again improved with pyridostigmine, and her symptoms actually resolved again after she was placed on prednisone, but she was unable to taper below 15 milligrams a day of prednisone without her symptoms coming back. So at this point, she was started on azathioprine as a steroid-sparing agent, and over the last 2 years, she's been successfully maintained on azathioprine and a small every other day dose of prednisone and been fully asymptomatic. Since she has become pregnant, she has remained asymptomatic from a myasthenia standpoint. And of note, this was a planned pregnancy. She is married. She's had no prior pregnancies or children. I think this case really exemplifies how it's important that in a young woman who's been diagnosed with myasthenia, it's really important that counseling around pregnancy should begin essentially at the time of diagnosis. This patient was doing quite well. She was asymptomatic and really didn't think to go to her neurologist to talk through any sort of pregnancy considerations before attempting to become pregnant. And so at the very start of diagnosis, counseling the patient about what she might expect is very important. On the one hand, it's certainly helpful to know if a patient is thinking about pregnancy in the near term, because it might influence things like what steroid-sparing agent or what overall medication regimen we might choose safely in a patient like this. And of course, on the converse, if we choose to start a steroid-sparing agent that is less safe in pregnancy, appropriate counseling around contraception would be key. Another important factor, though, is that the timing of pregnancy really might influence how well a patient with myasthenia does during the course of pregnancy. About 20 to 50% of patients with myasthenia will have their symptoms worsen during the course of their pregnancy. This is much more likely if their myasthenia is active and under poor control before the pregnancy. On the contrary, people that are really stable tend to do well and remain stable during their pregnancy. And actually some patients, in that sort of 50 to 70% that's left over, actually improve during the course of pregnancy. And so, in general, we want to try to time pregnancy, if we can, for a time where the disease is under good control. In terms of potential complications of pregnancy, premature rupture of membranes tends to be most common among myasthenic patients. In terms of treatments for myasthenia during pregnancy, pyridostigmine, which is an acetylcholinesterase inhibitor, a symptomatic treatment for myasthenia, is considered first line. It's been shown to be quite safe. Likewise, prednisone is the immunomodulatory or disease-modifying therapy of choice during pregnancy. When it comes to steroid-sparing agents, azathioprine and cyclosporin would be the preferential ones. They've been shown to be relatively safe compared to the others. A quick note, in treated male patients, azathioprine can cause mutagenesis in sperm. So it's recommended that if they are trying to become pregnant with their partner, that this drug should be stopped about 3 months prior. By converse, mycophenolate and methotrexate are not safe during pregnancy. They're known to be teratogenic, and so these should be avoided. So our patient, she's already on azathioprine and prednisone. And, certain patients may rightfully, think about, well, might it make more sense for me to stop these medicines to really eliminate any risk to my developing baby? It turns out that, with myasthenia, abruptly stopping medications would put a patient at quite high risk for an exacerbation or even MG crisis, where they, require ventilatory support. And so a patient like this who's doing really well, very stable, the best course of action in general is just to maintain her on this treatment that we know works and avoid any risk of relapse during pregnancy, which in its own right could be quite risky to the developing fetus. As a final note, both IVIG and plasma exchange are safe to use during pregnancy if a patient develops a relapse or exacerbation of myasthenia symptoms. So what about delivery itself? We know myasthenia is a disorder that causes fatigable muscle weakness, and so this could of course be a concern during labor. So no matter what route of delivery is selected, it's important that the patient deliver at a setting in which specialty care and ICU level of care are available for both mom and baby. Aside from that, though, guideline consensus statements really support the idea that vaginal delivery is a good, feasible option for patients with myasthenia gravis. And in general, we should only turn to C-section if there's a standard obstetric indication for doing so. Smooth muscle is not affected by myasthenia. So really the concern here would be in the active second stage of labor when skeletal muscle is important. And we can actually use acetylcholinesterase inhibitors during that time to help limit fatigue. And if absolutely necessary, forceps or a vacuum assist can be used. In terms of other considerations, epidural or spinal epidural anesthesia is safe and actually much more preferable to general anesthesia for a patient with myasthenia. And for those that are on a higher dose of prednisone daily, a stress dose of IV steroids could be considered prior to the delivery process. So for our patient, we instructed her to monitor closely for recurrent symptoms of MG. She was referred to a high-risk maternal fetal medicine specialist, and she was able to meet with anesthesia before coming in for delivery. Azathioprine and prednisone were continued at their current doses. At about 30 weeks, she did have some mild double vision come back, maybe 2 or 3 times per week. She restarted just PRN, pyridostigmine, and this helped. She was basically, minimally symptomatic after that. And she was able to go through an uncomplicated vaginal delivery at term. Pyridostigmine was continued through delivery, and no assistance was required. But delivery is not the end of the game here, right? There's some considerations after delivery that are really worth pointing out. One of those is neonatal myasthenia, and this is caused by transplacental passage of antibodies to the newborn. This can occur in any type of myasthenia, even seronegative patients. The affected infant is going to have signs of weakness, including hypotonia and potentially even difficulty with feeding or breathing. And so it's recommended that newborns are watched for 48 hours after delivery to make sure this is not happening. Antibodies are not passed through breastfeeding in the same way. This is really a post-delivery issue. In very rare cases, we can see a really severe disorder called acetylcholine receptor inactivation syndrome, which occurs when mom has a high fraction of antibodies against the fetal acetylcholine receptor. This is very severe. It causes fetal arthrogryposis, among other things. And signs of this might be reduced fetal movements or reduced uterine size during the course of pregnancy. And so patients can be counseled to watch out for movements of the baby in particular. This is really very rare, though, and shouldn't be a major concern. The risk of exacerbation for patients with myasthenia is actually highest in the postpartum period, about 6 to 8 weeks after delivery. And occasionally, this can actually be the timing of the first presentation of myasthenia. If a patient is thinking about breastfeeding, this can certainly be actively encouraged because sort of many of the same medication considerations we talked about with pregnancy really hold the same during the breastfeeding period. So pyridostigmine and prednisone, quite safe. Azathioprine, same idea. As a final note, it's just very important to remember that patients with myasthenia are at risk for developing an exacerbation or worsening symptoms when they're exposed to certain classes of medications. And so some of the issues that can come up during pregnancy, for example, eclampsia, are often actually treated with some of these medications that we just can't use in myasthenic patients. So IV magnesium is a really big offender here. Likewise, many antibiotic classes can be dangerous for patients with myasthenia. So if you're thinking about prescribing a new medication to a patient with myasthenia, always good to just double check this list first. All right, let's move on to our final case. This is a 35-year-old woman who's noted to have left leg weakness 2 days after a spontaneous vaginal delivery of her first child. She initially, as the anesthesia was wearing off, felt some tingling along her medial left leg. And when she started to try to weight bear, her left leg would buckle under her. She has no back pain, subtle anesthesia, and she has normal urinary and bowel function. She underwent epidural anesthesia, which was uncomplicated. She did have a prolonged second stage of labor and was in the lithotomy position for much of that. The newborn weight was 4,400 grams, and this was a baby boy. On examination, she has normal strength in the face and the upper extremities, as well as the right leg. She has weakness of hip flexion and the knee extensors in the left leg. And you also note some asymmetric weakness of left hip adduction. She has numbness to pinprick in the medial left leg in the distribution you see here. And her left patellar reflex is absent. So what might be going on here? The concern that I would have here is that she suffered a compressive nerve injury during the delivery process. And this can actually occur in anywhere from 0.1 to 1% of all pregnancies and deliveries. The risk factors are what you see here. So first pregnancies, for sure. A prolonged second stage of labor, especially in the lithotomy position, a large fetus or excessive weight gain throughout pregnancy, instrumented delivery, and then any sort of pre-existing neuropathy, for example, from diabetes. The most commonly injured nerve is the lateral femoral cutaneous nerve. This is actually a pure sensory nerve that innervates the pink territory on the lateral thigh that you see here. So the symptoms would really be numbness and paresthesias in this territory. This can actually occur during pregnancy in addition to delivery. And the mechanism here is compression over the inguinal ligament where this nerve emerges. Obesity is a known risk factor for this condition. And so the weight gain that happens during pregnancy, as well as the growing fetus within the abdominal cavity, can be kind of an analogous situation here. After the lateral femoral cutaneous nerve, the femoral nerve and the peroneal nerve are the next most commonly injured nerves. The femoral nerve is completely distinct from the lateral femoral cutaneous nerve, and it innervates the hip flexors and the knee extensors, as well as the sensation to the medial leg. So with the history we learned about in our patient, this would be a primary consideration. This nerve is also typically injured at the inguinal ligament, and it can be bilateral in 25% of cases. The peroneal nerve supplies the ankle dorsiflexors, and so it causes a foot drop when it's injured. And usually injuries to this nerve occur distally at the fibular head, typically from external compression. Next, we would have lumbosacral plexus injuries, and then injuries to the sciatic and obturator nerve would be less common. So as I said, the distribution of weakness and sensory loss would make us think about a femoral nerve lesion in this case, but it's important to be sure about that localization. So let's look at some alternative considerations, right? So if we look at this table here, if we're suspecting a femoral neuropathy, we expect weakness of knee extension and hip flexion, depending on where the nerve is specifically injured. The hip flexors are innervated before the inguinal ligament, for example. But we learned that in our patient, hip adduction was weak as well. This muscle is innervated by the obturator nerve, not the femoral nerve. So weakness of this muscle basically rules out a femoral neuropathy and would make us consider instead either a lumbar plexus injury affecting multiple nerves, or perhaps a lumbosacral radiculopathy affecting the L2 or L3 or L4 nerve roots. The sensory loss pattern that we're seeing in the medial thigh doesn't really help us differentiate here, nor does the patellar reflex. You might wonder why it's important to be this specific about localization for these types of post-delivery complications. But I think it can really influence, the workup you might do, right? So in this case, in which we are suspecting a plexus or a nerve root injury, of course, the appropriate imaging would be in the lumbar spine or the pelvis. By contrast, if a patient presented with a foot drop and it really looked like a peroneal neuropathy, of course, it wouldn't make a lot of sense to image there. Instead, our focus would be much more distal out in the lower leg. Another really important thought here is that radiculopathy, although it's quite rare, is going to be managed much differently than any of these compressive peripheral mononeuropathies that we're talking about. It is important to note that this is very uncommon. A lot of patients develop low back pain during pregnancy, but actual nerve root injury is super rare. Likewise, you might think about a complication from the epidural, but really any of these complications in this day and age are exceedingly rare. The only thing I'll note though is that if we have one of these very rare cases where an epidural hematoma has formed, the nerve roots in the cauda equina are getting compressed, it is very important to address that as soon as possible. Outcomes are better that way. So we do need to still kind of keep up our suspicion and make sure we're not dealing with one of these conditions. And so I think in general, some red flags that might make us think about this a little bit more would be symptoms that develop at a delay of days. So, you could imagine a growing epidural collection would take time to start compressing the nerves. The presence of saddle anesthesia or bowel or bladder dysfunction. The commonly injured peripheral nerves that we talked about in delivery really don't cause either of these problems. And then other signs of radiculopathy, right? So a positive straight leg raise or severe back pain or radicular pain. Presence of any of these really should up the ante for obtaining imaging in the lower back. So what do we do in these cases? Most of the time, our management is really going to be conservative because these do tend to improve after delivery. Most women actually fully recover after 2 months or so. The presence of weakness in these patients, especially if you consider having to care for the newborn and dealing with, the ongoing weight gain from pregnancy itself, these patients are at high risk for falls. And so providing them with specific orthotics to help prevent them is a good idea. In certain cases, especially if a patient isn't recovering very well, an EMG could be considered after a few weeks to help better localize the problem, make sure we understand what's going on, and then offer some prognostic information about, how much underlying axonal damage has occurred, for example. So for our patient, we did obtain an MRI of the lumbar spine because of the potential localizations that we discussed. This was thankfully unremarkable. She was referred to outpatient PT and provided with a knee brace. And about a month after delivery, her weakness had gotten a lot better. And really by about the 3-month mark, she felt more or less back to normal. Well, thank you so much for your attention. Hopefully these cases were helpful in, kind of seeing the spectrum of what can occur with neuromuscular disorders during pregnancy. And I will look forward to your questions. Thanks a lot.